Now, moving on to our fourth section, that is, we'll be going through briefly the thromboprophylaxis. As you know, historically, as this operating theater, the procedure instrumentations have evolved. Although there is decrease in the chances of pulmonary embolism and DVT, but initially there used to be very common occurrence, especially with the DVT, which could have developed post-operatively. We'll be briefly going through the pathophysiology, the clinical feature, and its diagnosis, and we'll be discussing the incidence of thromboembolic events and their prevention in this section. So what is thromboprophylaxis? This is actually venous thromboprophylaxis deals with the three diseases. One is actually DVT, which develops usually post-operatively, especially after the knee surgery associated with total knee arthroplasty. Then is a pulmonary embolism, although it can develop with usually any long bone fracture, and it can even be, but usually it's more common with the hip procedures such as total hip arthroplasty, and complication of chronic venous insufficiency. This is all includes thromboembolism. As we know, there are certain risk factors which may predispose patient to these kind of a problems, such as age, obesity, prolonged immobility, malignancy, and then there may be associated thrombotic disorders as well, or certain like antithrombin 3 deficiency, protein 5 leading deficiency, protein C deficiency, S deficiency. These are also called hypercoagulable states, or hypocoagulable state, which actually puts patient at an increased risk of either developing thrombosis or bleeding during surgery. So we have to be very careful and evaluate patient pre-operatively. The patient does not have these kind of problems later on post-operatively. So coming to the pathophysiology, actually usually surgery, especially in orthopedic surgery, when we are doing the femoral canal preparation during the hip, or when we are doing certain surgery, for example, reaming of the intermedullary cavity, this is actually, it's at this point it becomes very thrombogenic. All these emboli actually thrown at a high velocity into the bloodstream, and which may eventually cause to thromboembolysis. Therefore, soft tissue exposure, bone cutting, and reaming should be done carefully and meticulously should be done, and all this because this eventually leads to decreases the chances of having a thromboembolism post-operatively. Usually, if the patient has a systemic hypercoagulable state and fibrinolytic inhibition, then there is always a chance that post-operatively, due to reaming, this may eventually patient develop DVT or pulmonary embolism. Usually, it's an interaction between vessel wall damage, blood components alteration, and venous stasis. This is actually classically it was described as was called as virtuous stride or varicose stride, which was actually venous stasis, hypercoagulable states, and intimal injury. These are actually the three problems which once initiate a cascade of a complicated process called as venous thromboembolism, eventually leading to DVT. Coming to the in hip replacement, what happens is actually there's an obstructed flow in the femoral vein. Why? Because we may be reaming at very high pressures. Then there is a damage to endothelium and eventually leads to concentration of clotting factors. Usually with hip procedures, there is high likelihood of, especially during the femoral canal preparation, that patient eventually will have a pulmonary embolism. In knee replacements, there could be local endothelial damage as well. Relative immobility following a lower limb surgery, usually post-operative, all the exercises are being advocated, but patient remains in bed for at least 2 to 3 weeks or 4 weeks, or there is minimal mobility. Therefore, this results in venous stasis and eventually increased chances of DVT with total knee replacements. Actually, this is important that as the surgery has evolved, it was noted initially that beds actually which was used, operating tables which were used for the surgery, were highly hard and actually were metallic. Usually this predisposed them for the increased chances of DVT. Therefore, then there was slightly change in this operating tables as well, that the operator, instead of having a hard surface, they had a soft surface. But then it was noted, although the rate has decreased, but it has not decreased enough. Then post-operative use of stockinets, so that and this muscle pumps, and then post-operatively use of increased immobilization actually drastically reduce the chances of post-operative DVT. So what are the clinical features of DVT? There's usually asymptomatic pain in the calf or thigh, which is the classical history of having a 2 weeks or 3 weeks back there was some kind of a surgery. Now the patient complaining of pain in the calf or the thigh area. Usually there is no signs, but sometimes swelling and mild swelling and erythema may be present as well. There may be increase in temperature and pulse. Calf swelling and tenderness may be positive. Usually it affects the knee and the shin as well. With the edema, there may be shiny appearance of the calf area or the shin area. Called the Hoffman sign usually is done actually in which there is a dorsiflexion of the foot causes pain and actually ache in the gastrosoleus area or in the thigh area. But that actually is not very pathognomic of DVT. It could be positive in multiple other conditions, or it could be falsely positive as well. Therefore, Hoffman sign is not indicated. Usually do is venography, so basically, or duplex ultrasonography to diagnose a TVT in the veins of the patient. Now coming to another disease of which is associated with venous thromboembolism is called as pulmonary embolism. Its feature actually include pleuritic chest pain that the patient usually after either hip surgery or a long bone fracture, once the reaming was done, interlocking nail was done, usually within 48 hours, 24 to 48 hours or 72 hours, patient starts to have pleuritic chest pain, shortness of breath, and mainly it remains asymptomatic. Now, this is called as a Gould's criteria, which has actually 4 major and multiple minor criteria for this patient. If we get one major criteria, that is loss of consciousness, decreased PO2, or actually having a particular hemorrhages, or actually this kind of symptom, if one major criteria is positive, patient is diagnosed of having a pulmonary embolism. But if out of the minor criteria, which includes tachycardia, tachypnea, there could be hypotension, these kind of things, if 4 minor criteria come out positive, then we diagnose the patient of having pulmonary embolism. This could eventually be so severe that this may lead to a sudden collapse without even prior symptoms. Although this really rarely occurs, but this can be a possibility in case of it's a fatal pulmonary embolism. How to diagnose it? There is history examination, then we can go for the EBGs as well. With the classically actually either if the patient has died of this pulmonary embolism, usually post-mortem in the pulmonary arterioles would see a classical saddle-shaped embolus which may be visible on the post-mortem. But if the patient is alive, then we can use certain imaging studies to diagnose, such as it could be if it is in the superficial veins, venography, ultrasonography can be done, but usually for pulmonary embolism, the most important diagnostic evaluation is actually CTPA, that is computerized tomographic pulmonary angiography, which is the most important. Although VQ scan, ventilation coefficient scan, perfusion scan can also be done, but actually it's more cumbersome and time consuming, and sometimes a patient can easily, with the advancement of technology, the CTPA is readily available everywhere, so that is becoming more of a gold standard for diagnosis of pulmonary embolism. Coming to the post-thrombotic syndrome, it actually presents with usually leg discomfort and swelling, skin changes. If you appreciate over here, there's continuous swelling, there's skin changes, there is orangish discoloration and orangish peel of the skin usually, and this may eventually lead to ulceration because there is increased edema and fluid collection below the skin. These features of this post-traumatic thrombosis syndrome is usually sometimes they may be symptomatic or sometimes they completely asymptomatic. But usually the treatment is very much the same for both the pulmonary embolism and DVT, and that is prevention of these two conditions. Usually patients who have a chronic pulmonary hypertension usually is sequelae of those patients who survive a massive symptomatic pulmonary embolism. The patient had a femur fracture, let's say he was 22 years old, he had a femur surgery, interlocking nail was done, but he later on developed pulmonary embolism. Although he will eventually survive and got treated from ICU and discharged, but despite this survival, there is always a chance of he may end up developing right-sided heart failure. So how we can decrease the incidence of thromboembolic events? Although it's decreasing with time with the use of certain procedures such as more efficient surgery, meticulous surgery, and use of techniques especially which decrease the chances of thromboembolic events, earlier mobilization, use of prophylaxis, especially use of heparin and warfarin have actually decreased these chances markedly, and use of regional anesthesia. That is, instead of giving a general anesthesia to the patient, give a regional anesthesia, for example, bar block, upper brachial block, or saddle block, or especially spinal block, so that only numb the small area of the body. Blocking the, giving it a general anesthesia to, in which the patient becomes completely anesthetized. So then this is just a table which is actually showing how much risk of the venous thromboembolism. Just remember, with the pulmonary embolism, usually with the hip procedure and long bone fractures, there's increased chances of pulmonary embolism, and with knee replacement surgery, there is always increased chances of DVT. Now, how we can prevent it? That is actually by use of prophylaxis. Initially, heparin is given, or low molecular weight heparin has been introduced, which can be given subcutaneously. And then post-operatively, if the patient has developed, then we can switch to warfarin or Coumadin analogs. Usually, but we need to individualize the patient actually. First, we need to know whether the risks are present or not, and if risks are present, then we can start the treatment not only pre-operatively, we can continue the treatment post-operatively as well. But if this is only a risk factor, few risk factors are present, but the patient did not have any episodes, then we can only give these pre-operatively, and post-operatively we do not need to continue those drugs. General measures actually includes use of, as I told you, neuroaxial anesthesia, that is use of spinal or epidural anesthesia, which reduces the risk of VTE by 50% because the patient is able to walk and do exercises, whereas the patient is more pain-free. Other includes the surgical techniques, especially use of potentiated thromboplastin release, prolonged torsion, for example, in dislocated hip. There is actually increased with every dislocation is reduced in emergency as early as possible. So therefore, the dislocations are actually reduced over time, and they are readily reduced early. Therefore, there is a decreased chances of thromboembolism. And other options are different techniques being actually used, which actually decrease the showering of emboli into the venous systems. Other techniques include tourniquet. Usually tourniquets have been utilized, but sometimes you need a tourniquet for a surgery. But if the surgery gets prolonged, then there is nowadays the tourniquet is deflated for some times, then packing is done, and then again reinflated, so that there is a decreased chances of development of thromboembolism. Other options include, which actually hyperemia on tourniquet deflation can be positive, but this usually does not increase. This may increase chances of bleeding, but not the risk of thromboembolism. And the most important was actually use of early mobilization. The more the patient starts mobilization, there is decreased chances of stasis. Although there is intimal injury, but that a varicose triad, that first there is venous stasis with intimal injury and then the thrombosis. This actually, all this chain is broken by use of mobilization, and there is reduced venous stasis. Therefore, the patient does not have that amount of thromboembolism later on. Simple physiological means that actually improves venous flow. That is why decreases thromboembolism. In this section, we have briefly gone through the risk of thromboprophylaxis and venous thromboembolism. Just remember that the patient has to be assessed properly, and if the patient is a high risk for surgery, it does not only needs prophylactic thromboprophylaxis before surgery, but also post-operatively as well. But for surgery, we need to look out at the cofactors which are causing DVT or which may cause pulmonary embolism in patients, especially in the old age patient or who have thrombotic deficiencies or certain hypercoagulable states. Keep watching sqadia.com. Thank you very much.